This song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Thank you all for joining us for our first real webinar for 2023. My name is Agnes Ronan. I am from PATA and I'll be chairing your session for this afternoon. So today's webinar, we're in South Africa and we have 3 great cases from our partners from the Unfinished Business Consortium here in South Africa, as well as 1 case from the National HIV, TB and Healthcare Worker Helpline, again, also here in South Africa. So yes, so this is what, if you've ever wondered what REAL stands for Review of Cases That Health Providers See on the Frontline, engaging peers, as all of you on this platform, and hope that each one of you will have something that they will take away from this session. And at the same time, as I mentioned, accessing advice from our expert panel. So I hope that together we'll learn at least a lesson or 2 today from each other's experiences. So that's what REAL stands for. And then next slide, please. Thank you. So the format of our session is that our health providers will each present their case. And after each presentation will be our expert panel commenting. So we'll have a clinician commenting on the clinical component of the case, and then a psychologist providing remarks or recommendations around psychosocial support relating to each case. And this is something that we're quite excited about, the fact that we've got a psychologist on the panel, something that we introduced with our last webinar due to demand from health providers that we were mainly focusing just on treatment and not thinking about, you know, how there's a whole big context in children and adolescents' life around their psychosocial aspect of their life that impacts on whether children do well or not in treatment. So we're very excited to have a psychologist on the panel. So let me start by introducing our panelists first. So as mentioned, we have our psychologist, Bahati. Bahati is a psychologist from Newlands Clinic, all the way from Zimbabwe, Harare in Zimbabwe. And then we have Dr. Mo Achiri, who I'm sure you're all familiar with, from King Edward Hospital, the 8th, and the University of KwaZulu-Natal. And then lastly, we've got Dr. Nandita Sugari, who's a clinician who serves on the PATA Technical Advisory Panel, but also from ICAP. And lastly, I just wanted to remind you before we delve into our cases, please, we would really love to know where you're all from. So if you could type your name, your facility name and country in the chat box, so we can, and if you're not on our mailing list, I'm hoping that you all are because you've received this invitation. If you're not on our mailing list, please do include your email address as well. So today as I said, we've got great cases. The first couple of cases are focusing more on the psychosocial aspect of treatment and support. So we'll hear the first case is from Nomsa Zikali. And thank you. Nomsa is from Anova Health Institute here in South Africa, and she will present her case. And then following that, Bahati will step in and comment on the psychosocial aspect. And then Mo will comment on the clinical aspect of treatment and support. So I will hand over to Nomsa to present her case. Over to you, Nomsa.
Oh, okay. Thank you, Agnes. I'd like to introduce myself. My name is Nomsa Zikali. I'm from South Africa, Johannesburg, and I'm a social auxiliary worker from Anova Health Institute. So the case that I'm presenting today is a case of a 19-year-old female who was diagnosed with HIV in 2019, in October the 15th. And she was initiated on that on the same day. This young adolescent stays in Johannesburg with a family friend. Her mother lives in another province. Her father is not known. She was not born with HIV. She was sexually active and she contracted HIV. The good news is she has a 2-year-old child who is HIV negative, and the child is developing very, very well. She is the only one living with HIV in the family she is staying with now. She has disclosed her status to her mother and the people she lives with, and also to the father of the child. She received a child support grant for her 2-year-old grant, and the adolescent dropped out from school in 2020. But now she is enrolled at a college. She has no safety or support network. Currently takes care of herself and her little child. So yeah, next, clinical evaluation and current challenge. As I've mentioned on the first slide, that she was diagnosed in 2019 and initiated in 2019 in October. So her first regimen, her baseline regimen was TEE. And then in 2021, she disengaged from care for the whole year of 2021. And then she came back in 2022. And then in October, her current regimen is TLD. And she has no opportunistic infection because now she's virally suppressed. A medical intervention and course of action already taken was a regimen optimization to a TLD regimen. And other support or referral provided. In April of 2022, the patient was referred to a social auxiliary worker for psychosocial support. And the social auxiliary worker enrolled her to her case management for extra support or for psychosocial support. And she recruited the adolescent to a YCC support group. And then she was also referred to a local CBO for food parcel and Vuchilo 3 support group session. Next slide. Okay, and then this is a table that indicates her VL, her viral loads. So in 2019, she was initiated on TEE. In 2020, her viral load had 147 copies. And in 2020, September the 4th, her VL, viral load was 49 copies and continued on TEE. In 2021, she was a loss to follow. She disengaged from care. And then in 2022, when she came back, she had presented herself with a body rash and then with a VL of 75,600 copies. She was reinitiated on ART and continued with the regimen TEE. In 2020, and also enrolled, as I've mentioned on the previous slide, that she was enrolled on SO caseload for enhanced and adherence counseling. And then in 2022, March of the 3rd, her VL was 547. And in 2022-04, FVL dropped again. It was 250 copies. Continued with TEE. And then in 2022, in September the 1st, she was changed to TLD. And after that, in October, her VL was 19 copies, which is lower than detectable in simpler terms. So next slide. Okay, the key challenges that we experienced: the adolescent may have disengaged to care because she felt abandoned by her mother. She needed a sense of belonging. She is staying with a family friend, not her family. She has anger issues that sometimes affect her adherence to medication. She was referred to a psychologist, but she is still on the waiting list. Lesson that we have learned during this case: adolescents have a lot of underlying issues that contribute to them not adhering to medication. And then the second lesson that we've learned is that psychosocial support is intensely needed for them to thrive. And then knowing the adolescent family circumstances is very, very important in order to provide appropriate adherence counseling. Oh, the questions that I have for the expert panel, this patient was changed from TEE to TLD. And while TEE has only one unsuppressed VL result recorded, could this have been a case of drug intolerance or side effects? Are there any recommended lab tests that the facility should have done before they switch to TLD? And the third question is, do you have any advice for frontline providers while their clients are waiting for psychologist appointment? And the fourth one is, what should we look out for in HIV exposed but negative children? This is I think it's not in the slide. It's just my question that I have in mind. So we can just put it there so that the panelists can see the fourth one, if it's possible. The fourth question.
Thank you, Nomsa. I'm hoping that the panelists have noted your fourth question. And if you have other questions, I mean, I know we only had 3 in here, but if you have other questions, then please feel free to send in Q&A or to Angelita or myself, and we'll make sure that the panel has your question. So thank you for that great presentation. Gives us quite a lot to work with. So I would like to hand over to our expert panelists. And for this one, Bahati, if you could start by maybe giving us your comments on the psychosocial component, and then Mo, if you could move in after Bahati and comment on the psychosocial aspect. Thank you.
My camera not on.
Thank you, Agnes. Hello, everyone. Thank you for your presentation. I agree with your key points where you said that psychosocial support is important. I think often we think of it as a nice to have, but it's often something that should be a standard part of care for young people, especially. So your question was related to what can I do as a frontline worker whilst she's waiting to see a psychologist. I think it would be important to do an intake assessment. So the intake assessment is taking your client's history, their family history, their social history, their educational history, their sexual health, everything that concerns them from a biopsychosocial model, to understand their life events. So I noticed she was lost to follow-up 2021. This coincided, I think, with her pregnancy. If you take an intake assessment, you'd be able to know, was this postpartum depression? What were the circumstances leading up to the pregnancy? How did she process this? Was this consensual? So that you know what services that she will need. I also think it's important as a frontline worker to do mental health screens. Things like the PHQ-9, the suicide assessment, an assist for substance use, screen for trauma. These are screens that are available online, and they're free and they're translated into different languages. They're quite simple to use as well. It will also give you information of the severity of, for example, the depressive symptoms, if she does have depressive symptoms. And when you refer to the psychologist as well, she would be able to refer with some knowledge that maybe she needs depression support, anxiety support, and to know then what to expect when the psychologist sees her and does these treatments. You'll be able to know that, okay, I did screen for this, so I'm expecting the psychologist to address some of these key issues as someone who will be seeing the person regularly. I think it's also important to strengthen her current active referral systems. I think she's part of different peer groups, to find out from her, how is she responding? What's the progress with that? How is she finding them? Any key issues that she's noting, any strengths that she's getting from these current referrals, checking whether she's actually going. Sometimes we refer without following up whether the young person is attending or not, and how they're experiencing these groups. I think in the meanwhile, while she's waiting for her psychologist appointment, these are key things that you could explore with her. I think something that I also noted with this case is that her father is unknown and her mother is in a different province. Exploring how she's coping with that, not knowing part of her identity. What are the family dynamics that led to her not knowing her paternal side of the family? How is she coping with that? Are there any instances where you can invite the mother for a session? Are there any ways that you can activate her current support system where she's staying? I think these are things that you could focus on in the meantime. Behavioral activation, things like advising people about exercises, meditation. It's important to find out what are their interests. I think these are things that can be done freely at no cost, that people can start initiating before you refer to the specialist. Thanks, Agnes.
Thank you.
Thanks. Yeah, I think those are all. I mean, it's wonderful having a psychologist to give truly a comprehensive assessment of what goes on in these patients. I mean, just to speak about, I think in this patient, and one of the things that we do need to note, if you look at your viral load in terms of response to treatment, she did have quite a brisk response to treatment. So I think when she's engaged in care, there seems to be quite a good engagement with the care and a good adherence to the treatment. I think really around where we do need to really emphasize is why did she disengage from care, and what are the reasoning behind it, and where are the things that we can do to not only sort out the reasons for that disengagement from care, but also preventing future episodes of disengagement. Because I think that's probably the biggest risk for this this young woman. I see there was a note in the chat that she did disclose at some stage that she had attempted suicide. So there's certainly a lot of psychological issues that haven't been addressed and do need to be addressed in order to ensure that she remains in care with this patient. I mean, I think it's more likely with this patient, just to address the first question, that this was more likely to be a psychological issue in terms of why she's disengaged in care, or disruption in a social network, which is extremely difficult, especially in a really young mother who's got responsibilities and has not the the amount of support that you would want in that patient. So I think those are the things that you need to be worried about. To answer the second question, really around what are the recommended laboratories that need to be done before switching to TLD. So I think the main thing that we want to emphasize, and again, I think it was emphasized in the HIV Clinician Society guideline that came out last year and will be re-emphasized in the national guideline that should come into place in April of this year, is that we're not recommending doing a viral load or monitoring the viral load prior to switching from TEE to TLD. And the reasoning behind that that recommendation is a study called the Nadia study. And the Nadia study looked at patients who were randomly switched to either darunavir, ritonavir, or dolutegravir as part of their second-line treatment. And as part of a secondary analysis of the study, what they looked at was in patients who had a resistance to either of the NRTI backbone, what is the risk of biological suppression in those patients? And in that study, what it showed was that even if you had some resistance to the tenofovir or the emtricitabine or the limivudine, it did not impact in terms of the risk of transmission. So again, just to reiterate, we're not recommending that you that switch needs to have a undetectable viral load, and that you don't need to repeat the viral load or a recent viral load from switching from TE to TLD. Obviously, because the patient's on tenofovir, there has to be that routine monitoring of renal function, and so there's a need to monitor that as an ongoing basis, but it doesn't. This patient was on tenofovir before, so it's part of that routine monitoring. So there's, again, nothing specific that you have to do that's different from what you were doing with TE versus doing with TLD. So I'll stop there, and I don't know if there's any questions, and then we can take it from there.
Okay, thank you for answering that question for me.
Oops. Excellent. Thank you, Nomsa, and thank you, Bahati and Mo. I'm not going to summarize any takeaway after each session in the interest of time, because I want to make sure all our presenters have a fair chance to present. We will at the end have 1 or 2 slides, maybe highlighting what we think the key takeaways are from this session. So I will move on to our next presenter, and that's Yushia Mokaba. Yushia is from Temba Community Health Center in Tshwane District. As I mentioned, all the cases are from here in South Africa. So Yushia, please go ahead. I'm sorry, while we're waiting for Yushia to come on, I see that the 4th question has not been addressed, but I'll make a note for us to come back when Mo next comes back on to after the next session. Unless Mo, you want to jump in now quickly?
No, I think what we should do is maybe, and there's 2 hands up, so maybe we can, whoever's got their hands up, and maybe we can put the question in the chat, and I'll answer it in the Q&A.
Thank you.
Okay.
Yushia, are you okay?
Yes.
Yeah.
Can you hear me?
Yes, we can perfectly.
Okay. Good day, everyone. My name is Yushia Mokaba. I'm a clinical nurse practitioner allocated at Tembu Clinic, Tshwane District in Hammarsdrift, at South Africa. And I'm going to present a case that you answered while I was working at Jubilee Gateway, still at the same sub-district. We had a 14-year-old male diagnosed HIV positive in November 2018 at the age of 9 years. The biological mother has passed away, and the child is currently staying with the father and the stepmother. The stepmother is employed and the father is self-employed. The child lives with 3 siblings from the stepmother, and father has 3 more kids of unknown HIV status. The father is HIV positive and then he delayed starting art, but is now on treatment. Partial disclosure was done. Full disclosure not yet done, as the father is not ready to do the disclosure, and ongoing psychosocial support is continued. The child is involved in managing treatment and visit with adherence support, enhanced adherence counseling, and caregiver support. Psychosocial screening was done according to psychosocial screening model for youth clubs and enhanced adherence counseling. Child is also part of the youth care club. In clinical evaluation and current challenges, the patient was diagnosed 1st of November 2018 and ART was initiated on the 1st of November. Baseline regimen was abacavir, lamivudine, and efavirenz. Current regimen is abacavir, lamivudine, and dolutegravir, and is also on cotrimoxazole. Clinical presentation: the child had TB and completed treatment from November 2018 till May 2019. Medical intervention and course of action that was already taken was treatment regimen optimization to abacavir, lamivudine, and dolutegravir. Challenges in management: the child is always sick, sometimes misses school, and he has sore scars all over the body and it was not going well. The father was not actively involved in care, and at the start, when we were busy giving the child psychological support, he was not yet on treatment and was also in denial of the child's HIV status. Clinical evaluation and treatment history. The information was obtained from Tire.net, whereby November 2018, the TB smear was done, whereby it was the discharge smear for TB treatment, and then viral load trend April 2020 was 124, and June 2019, the viral load was 3,746,306 copies. And the regimen was switched from abacavir, lamivudine, efavirenz to abacavir, lamivudine, dolutegravir. July 2020, the viral load was 268,277 copies. And the regimen was switched from abacavir, lamivudine, dolutegravir to abacavir, lamivudine, efavirenz. September 2020, the regimen was switched from abacavir, lamivudine to abacavir, lamivudine, and dolutegravir. September 2021, that's when the child was transferred into our facility, and then he was seen with no complaints and was clinically well. And then regimen was given was abacavir, lamivudine, dolutegravir. Cotrimoxazole was also given, and treatment for 2 months. Health education was given to the caregiver. February 2022, child was clinically well, no complaints raised. Regimen continued and was referred for psychosocial support and counseling, and started on enhanced adherence counseling after February 2022. June 2022, client was clinically stable. Stepmother reported that the child is always sick and sometimes miss school. Viral load was 927,000 copies. The regimen was continued. Viral load repeated 1 month. Was repeated 1 month, return date given, and health education was given. September 2022, the stepmother was involved in treatment support. Stepmother reported that he is now giving the child treatment correctly. The regimen was changed, was continued, health education continued, and enhanced adherence counseling sessions were done with ongoing psychosocial support, and the viral load was 45 copies, which was suppressed. And then when the originating facility was reopening, the child was referred back to the originating facility and was switched to single drug TLD. Client was seen for 3 consecutive months with the stepmother for enhanced adherence counseling and psychosocial support. The stepmother was very receptive of psychosocial support and was given treatment accordingly. Pill count was done every visit. The father was not ready for the child to be stated to be close to the child. Next slide. The key challenges was the clinical records were not complete, incomplete information from the referral letter from previous clinic, not fully indicating regimen changes, start date, viral load, and baseline blood history. Father was initially in denial and was not willing to take ownership of child's treatment. But the stepmother was tested negative, but was willing to assist the child with taking treatment. Lessons learned are clinic visit monitoring must integrate clinical and psychosocial services. Assessment of socio-economic status of the child on ARC is necessary as it affects adherence and ARC administration. Intensive education on pediatric ARC and viral load monitoring and management with caregiver is important. Priority for intensive monitoring in those who are attending psychosocial support as they are required to attend clinic more often. The question I would like the expert panel to ask is that after how long should drug regimen changes be done? And does that affect the treatment outcomes of the patient if changes is done too soon? The other one, how repeatedly do inappropriate ARC single drug switches need to be rectified to avoid safety concerns in pediatric patients? Then, are there any indication for cotrimoxazole use in pediatric ARC patients besides opportunistic infection in low CD4 counts? And what could be the way forward in addition to ongoing disclosure support for and psychologist appointment? Thank you.
Thank you, Yushia. That was great. And I will hand this one over to Nandita first, and then Bahati, if you can step in after Nandita. Thank you.
Great. Thanks, Agnes. And thanks for a really great case. I think we're still seeing, you know, these children who are diagnosed late in life. And I think your point here about sort of not having the full records really brings home, you know, we have to piece together the history of this child. So in terms of your questions, how long should drug regimen changes be done? After how long? And does it affect the treatment outcomes of the patient? So this is a good question, because we actually have two different reasons for, well, we have different reasons for changing a drug, right? So most recently we had optimization, where we've had drugs that don't work as well, so efavirenz in our case, and we have shifted to dolutegravir based regimens, knowing that it's a much more potent regimen and has a higher genetic barrier to resistance. So in that case, that was an optimization switch. But there are other reasons why we may switch. So we may switch because of treatment failure. And again, in this case, it may depend on the type of drug that was used. So again, we switched from efavirenz, knowing that efavirenz-based regimens, you can develop resistance relatively quickly. And then you would want to make sure that that client is put on an effective regimen. Whereas with dolutegravir, we know because it's a higher genetic barrier to resistance, we may take some more time. So it depends on the regimen that's used and the reason for switch. There are other reasons for switch, such as intolerance. So there's some, and though it's not frequent, we do see that there are some people who cannot tolerate dolutegravir or may have trouble tolerating other ARVs that they've been prescribed. And in that instance, you do want to change, because if somebody is having intolerance, that may be a sign that they're not going to take their drug. So you really want to weigh the risks and the benefits. You don't want to change too soon. You would want a regimen to give it a chance to have an effect, but at the same time, we have to keep in mind that there are changes in the program to introduce better drugs, and there are different reasons. So I think that question of how long should the regimen, after how long should it be done? Now with failure, so it really is sort of based on what the program is, and then based on what the drug is, or the drug regimen is, and the reason for change. in terms of the inappropriate ART single drug switches, I'm trying to understand this question a little bit. How, and again, I think you're bringing up some safety concerns. So I wonder if this has more to do around side effects, or worries about other toxicities related to a single drug. In this case, we could also be talking about switching from TLE to TLD, which is again a single drug switch. And in terms of inappropriate or appropriateness, sometimes if somebody is on a stable regimen and they have a suppressed viral load, we would want to keep them on that, especially if there are other issues going on, whether it's a young woman who's pregnant, or whether it's, in this case, maybe this child, because of his TB treatment, they opted to keep him on something he was already taking. But in terms of making an appropriate switching out dolutegravir or switching efavirenz for dolutegravir is considered a very safe switch. And so we haven't seen adverse events with that switch. And as Mo mentioned earlier, the Nadia trial was done showing that even if there was even if an NRTI backbone, so in this case, abacavir and 3TC, were used with an NRTI that failed, that backbone could still be recycled into the next line of therapy with dolutegravir. Now, I will say that the Nadia study that we're basing this on was done mainly with tenofovir-based regimens and not with abacavir-based regimens. We're still looking very closely at that, but at this point, we haven't seen significant reasons to be concerned about that switch. So at this point, making that single drug switch is a safe switch to make, even if the rest of the regimen doesn't change. In the third question about indications for cotrimoxazole, I think this is a really great question. I had noticed in the patient's history that Cotrim had been started at a later point. I think you're correct in terms of we needed sort of more of a history. We didn't have his CD4 count or his other labs, or more detail to understand what his physical status is. And so cotrimoxazole is beneficial in preventing OIs, particularly PJP, which we see quite often in younger infants. And there is a debate about when we should stop giving Cotrim to those older children if they're doing well. And one of the considerations is really the setting that child is in. So there's some evidence that cotrimoxazole may help in reducing diarrheal illness, may help in reducing the severity of malaria infections. Now, again, this is not something that is going to happen in every country, and we always have to weigh that against the risk of antibiotic resistance developing. And so this is sort of a country by country or situational sort of a decision to make. And Dr. Mo may have some additional comments about that based on just his experience in South Africa, in Durban in particular. And then in terms of disclosure support, I know that Bahati probably has a lot more to say about this than I do. I mean, one thing that I do want to point out is that this is a child who's now, well, a young adolescent. So he's 14 years old. He's in school. Even if he's missing school, he's still in school, and he's part of peer groups. And so that brings up a question for me of how much does he really understand about HIV? What has he learned so far? Is he hearing messages in school or from peer groups? And even though in his home situation, his family has not been fully disclosed to, he may have be picking up different perceptions outside of the home. And so that's one thing to consider. And Bahati, I'm going to hand off to you to talk a little bit more about the psychosocial issues. But before that, Mo, I don't know if you have any additional comments on the Cotrim.
Yeah, maybe just to quickly say, I think there's been a slight shift in the South African guidelines And so I think I put into the chat with the Q&A. So the new guidelines in South Africa will not recommend starting cotrimoxazole prophylaxis in all HIV-exposed uninfected children. So you'll only start the prophylaxis once the HIV infection has been confirmed. So once you're starting antiretroviral treatment, you will start the treatment. You'll start the cotrimoxazole. And you continue the cotrimoxazole for at least for the first year, but certainly until the CD4 count recovers. Because certainly, if you look at your PJP incidence, it's largely in that first year of life, predominantly in the first 6 months of life, and then thereafter it occurs in older adolescents and adults when the CD4 count drops. So I think that's just the main change. And I'll try and get the Nadia study, and I'll put the link in the chat.
Great. And just again to point out that what Dr. Mo is explaining comes from the South African guidelines, but again, every national guideline may treat this a little bit differently. So it's always a good idea to check.
Thank you, Nandita. I agree with you when you mentioned that he's in school. This is a pre-adolescent who's in school, who probably has a lot of whispers around his illness. I think it would be important when speaking to the family to highlight that from clinical practice, just what we find is young people who are disclosed to late seem to experience more complicated post-disclosure issues. There is a lot of unresolved anger around why were people not telling me? Why were people being deceitful? When people were talking about me, they knew what was wrong, but they did not think it was okay to inform me. I think whilst we're thinking of that, it is important to also have compassion on the parents. The parents are probably coming from a place of fear, where they're worried as to what will happen when he knows, and guilt, perhaps, and anxiety about what will the family look like when he's aware that he is living with HIV and may have questions about transmission. That is often a big question that parents have. So I think treating this case as a family unit, the father himself seems to need also his own individual space where he can process his status, process his child's status, and think about disclosure. I think I would encourage the counselor or the nurse or the frontline worker to try and help the parents go through the inner world of this 14 or this young person. When you're sick, naturally, you want to know the cause, you want to know what's happening, and not being able to have a tangible answer could be quite anxiety provoking. So we could be also looking at things like anxiety that are coming from illness. I think it's important as well to screen this young man as part of the treatment plan. His mom has also passed away. He's now in a home with other children. The family support should also include finding out what that situation is like for him. Is there cohesion in the family? What do the other siblings ask with regards to his illness? Are there whispers as well in the family? So it might not just be in the school setting. I see that the stepmom is in charge of DOTS. I think it's key to have someone in the home at least who you can work with. It's also finding out how is this DOTS done in the home? How are they called? Often DOTS sometimes is an area of tension, where a young person is told, come and take your art, and they don't want it done that way. So to encourage the family to agree on how to support each other in terms of adherence. I think it would also be important to do a lot of post-disclosure work once you've got to a stage where the father and the mom agree to disclose to this young man. I don't believe in a one session of you're told you're living with HIV and that's it. If you have any questions, often there are questions that come even months down the line. It's important for the family to have a regular space where they can ask questions, they can receive correct information. If there are any psychosocial issues as well as a family, that they get that help. For the young man as well, if he needs his own individual space in the post-disclosure sessions, that could help as well. I think something that might be helpful for frontline workplace is also thinking of post-disclosure groups, like a holiday club for young people that you'd have disclosed to recently, where they can come together and process together and have that peer support. It would also be good if the healthcare facility is aware of parents who've also disclosed to their child or their young adolescents, to pair this with the caregivers who are struggling to disclose to this young man, and that maybe they would be able to get some practical experience, some first-hand experience of what was it like to disclose, what was it like after as well. So pairing the parents with other parents who have, or caregivers who have disclosed to their kids. I think it is also important that since he's been missing school, that he has a psychoeducational assessment to assess where he is academically. Sometimes a young person will need things like extra time in examinations or extra individual attention in certain areas because they have missed school or may have a learning difficulty. So if there is access to a psychoeducational assessment, I think that will be holistic for this young man. So he's not experiencing one missing of school, perhaps bullying, and then a low academic performance without support or without referral to support that would help him manage his academics as well. I think it's important to think of a young person beyond HIV, to think of them as a learner, to think of them as a friend, to think of them as having their own aspirations and not just focusing on the HIV treatment in itself. Thanks, Agnes.
Thank you, Bahati. I mean, yeah, I think psychosocial issues, especially when it comes to young people, is a whole minefield in terms of how we begin to even understand what's going on in their life, let alone support. So thank you, Bahati, for all your wise words on this. And I hope you've got something to work with from Bahati's advice. So now we'll move on to our next presenter, Anushka. Anushka is from the National HIV and TB Health Care Worker Helpline in South Africa. And Anushka, please, will pass the floor over to you.
Thanks, Agnes. I'm a pharmacist and the manager of the National HIV and TB Healthcare Worker Hotline, and I'll be presenting a slightly different case, focusing more on the drug treatment and potential drug interactions and problems with stockouts. So we were asked about a 19-month-old female diagnosed with HIV and TB in December 2022 when the child was 17 months old. The mother was RVD positive and unfortunately diagnosed during breastfeeding. There were two older siblings, 9 and 10 years old, RVD negative. So this child started drug-sensitive TB treatment on the 20th of December 2022 with RIF, INH, PZA, and ethambutol. And the big challenge here was that ART had not been started yet a few months later. And the reason for this was that the facility didn't have any access to ritonavir powder. So if we look at the treatment history, there wasn't a lot of treatment history, but the little bit that we did receive was that the child was unwell and coughing in December 2022, weighed 10.9 kilograms, had an HIV test, and gene expert was positive on gastric lavage, and then was on the 20th of December started on RHZE. The CD4 was 480. Unfortunately, there wasn't a percentage CD4 count available. And then in January 2023, They planned to start antiretroviral therapy, but kept on deferring as they couldn't get hold of any ritonavir powder. And because there is a drug interaction with rifampicin and the PI, they didn't want to start because they would be underdosing this child. In Feb 2023, the TB symptoms had improved, and we eventually, after a lot of consultation with pediatric HIV experts, decided to start the child on abacavir, lamivudine, and dolutegravir film-coated tablets because that's all we had available. And we had to obviously double the dose to negate the rifampicin interaction. Also, just to say, eventually in March 2023, we managed to source ritonavir powder, and this child was changed from the double dose dolutegravir film-coated tablets to lopinavir ritonavir with additional ritonavir powder. So what were the key challenges here? It was quite a challenge finding an appropriate ART regimen for a young child on rifampicin containing TB therapy who couldn't yet swallow any tablets. And we did not have access to ritonavir powder, and we also did not have dolutegravir 10 milligram dispersible tablets available. These are slowly being rolled out across South Africa, but in the Eastern Cape where this child was, there was no dolutegravir 10 milligram dispersible tablets either. We also had to take into account the drug interactions between both dolutegravir and lopinavir, ritonavir, and rifampicin, and then we had quite a limited medical history for this child. What have we learned from this case? Stockouts are problematic and can have serious consequences for patients, delaying initiation of ART in this patient. Doubling the dose of lopinavir, ritonavir is not appropriate in smaller children, those under 10 kilos. We actually need to provide them with extra ritonavir. We can't just double the dose of the lopinavir, ritonavir. And then also to take note that dolutegravir film-coated tablets and dolutegravir dispersible tablets are not equivalent. So you can't give 10 milligram of the one and 10 milligram of the other because the dispersible tablet has a higher bioavailability. So the doses are different. And then lastly, lopinavir, ritonavir tablets cannot be swallowed, must be swallowed whole, and cannot be divided, crushed, or chewed. So we weren't able to give lopinavir, ritonavir tablets and divide them, crush them, or chew them. This is just an example of an educational material that we develop, and it's available on our website, and the web address was on the first slide if you want to download this after this talk. But you'll see here basically that usually if a child is on dolutegravir when on rifampicin, we need to double the dose. If they usually get 2 10 milligram dispersible tablets a day, once they're on rifampicin, they need to get it twice a day. And then the same applies to lopinavir and ritonavir. They need to get the standard dose plus additional ritonavir powder, depending on their weight. So we had quite a lot of issues here because we couldn't get ritonavir powder for this child, and we also didn't have dispersible tablets, so we had to make a plan. So what we did is we basically took a dolutegravir 50 milligram film-coated tablet, and we cut it in half, and we gave this to the child, which would be approximately 25 milligram twice a day. And these lead to the questions for the expert panel. Would this be appropriate? And this child actually needs 20 milligram of the dispersible tablet and therefore 32 milligrams of the film coated. So we were slightly underdosing this child. And that's why when we managed to get hold of the ritonavir powder, we changed to lopinavir, ritonavir with extra ritonavir powder. And then I just wanted to ask the panel if they could have suggested any other options. Thank you very much.
Hi, yeah, thank you very much. I think always, I mean, these are the difficult, life things that happen that you don't have any much control of. And certainly, I think, one of the things, I think we just need to be, may need to push that, that there should be availability of drugs at all time, and we should not be accepting stockouts of any of those drugs. Ritonavir powder, the reason we moved from the syrup to the powder was really that it has a much longer shelf life. So, as opposed to the syrup, there was, was complete, constantly going, past its expiry date. So, there should be no reason why there should not be any ritonavir powder around. So I think a few questions, I think maybe just to go back and really go through the rationale. So the 50 milligram tablet, in terms of using it as an entire tablet, based on its dose, can only be started from about 20 kilograms. So from 20 kilograms, you can use the 50 milligram tablet, and then below that, and with a new guideline, when we move to the dolutegravir dispersible tablet, we'll be using it from 3 kilograms to 20 kilograms. The 10 milligram tablet is a scored dispersible tablet, so you can break it in half, and that gives you 2 5 milligram tablets. The problem with the 50 milligram tablet and how the tablets are designed is, when you break a tablet in half, unless it's scored by the manufacturer, you don't know whether the half you're giving has 25 milligrams or 30 milligrams or the entire actual dose itself. So the difficulty with it is when you're cutting tablets that are, or giving fractions of tablets that are not scored, you run the risk of either overdosing or underdosing patients. So I think it's not the most ideal situation, but obviously, some of the things that sometimes we have to do to get around these things. The other issue with the TB medication and lopinavir ritonavir. So with the syrup formulation, we're not recommending double dosing the formulation, the medication, because the PK seems that if you double dose the liquid formulation of Kaletra, you don't adequately compensate for that drug-drug interaction with the rifampicin. However, so therefore, with the syrup formulation, you have to give additional ritonavir with that formulation. However, with the tablet formulation, either you can use a pediatric tablet, which is slightly smaller than the adult Eluvia tablet. You can then give double dose, Eluvia tablets. And again, as you've indicated, these tablets, because they're film coated, can't be crushed or broken when given. So they have to be swallowed whole for these patients. So I think coming back to the difficult question is, what to do when your back is against the wall and you don't have, adequate amount of drugs. I think, again, none of these options are ideal, and, you're probably going to, maybe run in trouble, giving it as a long-term strategy. And I agree with your eventual idea is, because certainly I think you don't want to, not give treatment for a long period of time while waiting for drugs to be available. In terms of hierarchy of different options, again, there's no scientific merit of this because there's no data around it. I probably would have gone for double dose Kaletra syrup as a first option. Then the second option would be if the child was able to take the lopinavir ritonavir tablet, maybe double dosing and seeing where they could be taking it. And then maybe as a final option is to break the dolutegravir and then, giving it. I think the difficulty with that is, you don't want to give them suboptimal doses of dolutegravir and run into problems later on. The other point I wanted to make was really around the timing of TB treatment and antiretroviral treatment. And as you indicated, this is an inappropriate delay in between starting your TB treatment and antiretroviral treatment. So the WHO guideline has changed about, I think, a year or 2 years ago, whereas previously we were recommending that you delay your initiation of antiretroviral treatment when you start TB treatment. The current guideline, based on data of a meta-analysis of the risks associated with delaying the ART, what we found was that the iris doesn't tend to be life-threatening. However, when you delay the ART initiation, you run the risk of that patient disengaging from care and being lost to follow-up. So the current guideline, and that includes what we recommend in South Africa, is that you start both TB treatment and antiretroviral treatment at the same time. The only exception to that rule is if you have TB meningitis, because that's infection within a closed system, and you can get raised intracranial pressure with an iris type phenomenon, and that may be life-threatening. So that will be the only reason why a patient with TB treatment, you would delay initiation of antiretroviral treatment. So I think a temporary measure is fine, but I think as soon as you have the appropriate treatment, you should be switching to what's the most appropriate treatment for that patient. Thanks. Hope that answers the question. Nandita, do you want to add?
Yeah, no, I think Mo, that's a great answer. I don't think I would change anything. I was sort of thinking to myself, I'm glad that there was an opportunity to come up with something, because I agree it was a long delay before starting treatment, and we don't want to see that, particularly in a young infant. We know that the brain is growing and developing, and that's a very critical time period. So I agree that I think just if having that dose and sort of trying to come up with something, we often find ourselves in that situation in pediatrics in particular, where we really struggle to make sure that we have formulations that are appropriate, that children can take easily, and that we have the dosing right. And the dosing is something that I really want to stress here, because very often we will look in charts and we'll see the weight hasn't been written down, or we'll see that the dose hasn't been updated. And that's something, again, that's pretty different in pediatrics compared to what we do in adults. And so I just wanted to highlight, like, these are some of the critical issues in pediatrics. And then lastly, as we're switching over, and I think as many programs will start now have access to the dolutegravir 10 milligrams dispersible tablet, I just wanted to point out a general rule of thumb. They're not, when Mo was talking about that, or when it was mentioned that the film-coated tablets, the 50 milligram adult tablets that we often use for children 20 kilos and above, and in adults, is not the same thing as the dispersible tablet. They're not bioequivalent, so you won't have the same impact. But just a rule of thumb is 150 milligram film-coated tablet is roughly the equivalent of 30 milligrams of a dispersible tablet. And that's like a rule of thumb I keep in the back of my mind if I ever have to make this type of a decision. But it's a hard one, because we have very limited options. It's particularly for younger children in terms of TB, HIV co-infection.
Thanks, Nandita. Bahati, would you like to chime in and provide us with your reflections on the psychosocial component? Thank you.
Thanks, Agnes. Just a few thoughts were, just imagine being a mom who's just found out she has a chronic illness, her child has a chronic illness, medication has stocked out, and you're probably struggling to give a young person medication, what that experience would be. And this is a daily experience. So being aware of those psychosocial dynamics for the mom, could the stockouts be intensifying her guilt if she is aware of them? That now I'm not sure if my child will get treatment. What does that mean? And having to give a very young person medication could be a quite stressful time for a mom or a parent. and to just try and think of those things to discuss with them and to validate those feelings, to normalize those feelings, so that if there are any other complex issues, this mom is able to talk to her healthcare provider about these things. I think we just often focus on giving the dosing, the adherence messaging of what time it should be done. I think it's also important to validate the stress or the anxiety that could come with administering medication. Thanks, Agnes.
Bahasi, that's a great point. And I'll say particularly for ritonavir powder, because we know that that's not a pleasant formulation for anybody. And so I think that point about supporting the caregiver, particularly at the beginning where she's hearing some bad news, her child is ill, that, again, that support is needed to give that extra, drug. It's not going to be forever, but I can imagine it would be a very difficult time.
Thank you, and thank you both. In the interest of time, we'll move to our last presenter, which is by no means less complex than what we've had today. So yeah, brace up for this case. But so I'd like to introduce Dr. Nicola van Dokken. I hope I've said it correctly, Nicola. Nicola is from Rahima Musa Mother and Children's Hospital. Also, I mean, like everyone else here in South Africa. So I'll hand over to you, Nicola.
Can you hear me? Thank you so much for the opportunity to present. We will be presenting a 19-year-old female who had a concomitant diagnosis of pulmonary TB and HIV in 2005. She did complete TB treatments at the time for 6 months. She was living with her mother and her father, who both are on HIV treatments. Unfortunately, they separated in 2017, and she now currently lives with her mother, but their relationship is significantly strained. They have a lot of conflict and repeatedly have verbal and physical fights, which have been going on throughout her childhood. She's also living with a younger sibling who is 13 years old and HIV negative, and they often fight a lot as well, both physically and verbally. Since she was a child, she has had severe behavioral challenges that have spanned from early childhood all the way through adolescence and now into young adulthood. She's been managed in the past for oppositional defiance and conduct disorder. She's failed multiple years at school, and she also takes part in high-risk behaviors throughout her life, such as gambling, stealing, assault of individuals, and unsafe sex practices. She was disclosed to in 2015 at the age of 11 after very poor adherence and challenges with taking medication, which didn't really show that much improvement after disclosure. And she's now currently 27 weeks pregnant. Her partner is 21 years old and is undisclosed too. So I will speak a little bit more into the medical interventions on the next slide. But she's currently on a regimen of TLD as a last resort, we would like to say. But she has had multiple interventions to assist with the behavioral challenges that have been a part of her life. She's been seen by psychology, she's been seen by psychiatry, she's been treated with Ritalin to try and assist with the behavioral challenges. She's been working with the police departments in bullying programs. She's been working with social workers, peer support groups, and in reintegration programs as well. Our current challenges with her at the moment is that she's essentially been unsuppressed since 2016. During this period, both on a protease inhibitor and on an integrase inhibitor. She's pregnant with unsuppressed viral loads and poor adherence, and she has this behavioral challenge in terms of conduct disorder and oppositional defiant disorder. So just briefly to summarize, you can see she started treatment in 2005 and at the time also had TB, and she was initiated on a regimen of stavudine, lamivudine, and lopinavir ritonavir. She originally did quite well on medicine when she was quite young. You can see she had a viral load that was less than 20, and at this stage was switched to abacavir, lamivudine, and lopinavir ritonavir. But already in 2010, a lot of the defiant behavior had been recognized. From 2016 onwards, we really struggled to get virological suppression with her. That was with multiple interventions through psychology, psychiatry, the police services, necro services, and lots of adherence counseling from our teams. She was switched to abacavir, lamivudine, and atazanavir ritonavir in 2017 in an attempt to reduce the pill burden, to create a regimen that had fewer side effects, but we really still struggled. And in 2018, we decided to put her onto 3TC monotherapy because we were running out of treatment regimen options. Due to a low CD4, we actually had to switch her off 3TC monotherapy quite soon after starting it. Her CD4 dropped below 200. And at that stage, it was decided to put her onto first-line tenofovir, lamivudine, and efavirenz, which, to no surprise, she did not do well on. So she was switched back to tenofovir, lamivudine, and atazanavir ritonavir in 2019. Since then, no suppression in the viral load, and in an attempt to make the regimen even simpler and hoping that 1 tablet a day would help her, we switched her to TLD. Initially, we did see some response. You can see that there was a log drop in her viral load at the time that she was found to be pregnant, but subsequent viral loads have actually gotten worse again. So our key challenges in this case was the prevention of vertical transmission in an adolescent or a young adult who has quite significant adherence challenges. What regimen would we choose in someone who has got so much ART experience and has technically been on a dolutegravir-based regimen for almost 2 years? How do we manage HIV in the face of substance use disorders? And how do we manage a high viral load in adolescent or a young adult who has such significant behavioral issues? And then how to deal with the family relationships and the conflict resolution, especially because there is a baby coming into the picture. What we have learned from this case is that we need to identify and address social issues as early as possible. So ideally in the first few years of treatment. We need to identify how to manage the family unit and to create clinics that would better manage it. And our thoughts are at the end of the day that the patient's treatment outcome is also in their own hands. And should we be giving a greater sense of control or responsibility to our patients earlier on? Obviously, that's very difficult when you're dealing with oppositional defiant disorders and conduct disorders. And then the psychosocial environment and traumas have a significant impact on the treatment adherence and acceptance of diagnosis in HIV. So some of our questions for the expert panel was, what would be the best regimen for this patient? Should we continue her on TLD, considering that she's already been on it for almost 2 years? And that she's been on PIs quite extensively before with also limited success. Do we offer a treatment interruption to a pregnant mom, even though the CD4 count is less than 200 and our worries around transmission to the baby, but we're also worried about transmission of drug resistance? How do we feed this baby if the PCR is negative, if the mother doesn't improve her viral load and we are kind of reaching the 2 years on an INSTI? And if the baby is positive, how do we go about ensuring that there's going to be treatment adherence for her child? If she doesn't really have a great support system at home and she herself doesn't take her treatment well? And how would you manage the adolescent or young adult who has such intense behavioral challenges? Thank you.
Thanks so much for that case. That is a complicated case, and it's important to have the history. I had to go back and think through what years was this young woman on this regimen versus that regimen, and so forth. And she was, even also just the behavioral issues here definitely seem to play a big part in what's happening. So whether it is oppositional defiant disorder, these are behavioral issues with unregulated emotion, and that can be very challenging to manage. And so, but just going back to your questions, in terms of the best regimen, my thought, just looking at her past history, would be to continue on TLD. I mean, she did have an initial response to this, and it may have then Wayne, but I would stick with it because it is an easy to take regimen and it is a potent regimen. And prior to that, she had been on, I think it looked like she had been on LPVR with abacavir and lamivudine early on back in 2010. But then she had been switched to atazanavir later on, but it seems like that was just for a very short time. So, you know, again, I would think that as we had been discussing, using dolutegravir, even in the face of NRTI resistance, can still be very effective. So my thought would be to continue with the current regimen. In terms of treatment interruption, with her CD4 count so low, and with her, you know, and we're really worried about her pregnancy as well. I don't know that treatment interruption would be the right step to take. I think that would be, I think she definitely needs a lot more support. And I wonder if this is an opportunity to involve the family more. So I think with some of these behavioral issues, sometimes involving sort of family support, so the family or the mother also understands how to approach her daughter, especially given that this mother also has experience taking HIV medications. That may hopefully help, and I would really welcome Bahati's thoughts on that as well. In terms of, you know, we are entering an era now where we're seeing a lot of these young adolescent women or young girls who have grown up with perinatally acquired HIV and then become pregnant. In my experience, the best thing to do is explain to her the impact that this could have on her infant, on her unborn baby. So I think there's an important point to explore there, whether this was a wanted pregnancy, to also encourage her and to do what we can to bring in as much support during this time. There's a question around feeding the baby if the PCR is negative. And that's, again, that's a very difficult question in some settings. It depends really on the safety and affordability of formula as a replacement option. And so I think it depends very much on the circumstance. And again, we'd want to encourage to this mother, you know, the importance and stress the importance of maintaining a suppressed viral load during pregnancy, delivery, and breastfeeding, if that's something we can really explain to her. And this fourth question about the baby being positive, I think in general, it's not just if the baby is positive, but even if the baby is negative, we would want to give prophylaxis. Like, this is an infant that definitely should receive prophylaxis. And right now, current WHO recommendations are to give it to at least 12 weeks, with the expectation that a mother may start treatment at delivery and then would then have that time to suppress while the child is on prophylaxis to prevent breastfeeding transmission. Now, different programs may practice differently. There are some programs that do extend the length of infant prophylaxis throughout breastfeeding. Now, there's very, very little data available on this. So again, I would caution everyone to look at national guidelines. But this is a high risk scenario. So this is definitely one that we would want to do as much as we possibly can. And in some cases, we could even say HIV is probably the least of this young girl's problem. She really has some issues that are going to make it difficult for her to parent and for her to take care of herself if we don't address them rapidly. But in terms of the medical treatment, I agree with maintaining her on TLD, but really working on adherence and making sure she understands, and then bringing in the family as well to see where the family could support. Mo, I don't know if you have any additional thoughts on this one.
Yeah, no, I think it's always an extremely difficult, case, and really, I mean, often you're pulling your hair out, in these cases, trying to, try and getting the best outcome both for the mother but also for the baby. I think one message to probably make is, I mean, even the US guidelines now under certain circumstances are recommending breastfeeding for HIV positive patients, but certainly within the context of someone who's biologically suppressed and will remain biologically suppressed and adherent to treatment. And in this case, I think it's an extremely difficult situation, and you do need to really do kind of a assessment of what the risk-benefit ratio is, especially in the context where a mother may not be able to provide adequate amount of safe formula feeding, both in terms of the quantity of formula, but also in terms of the access to safe drinking water and the ability to mix the formula. So those are the conversations that you need to have, and part of that decision around the safe feeding practices for this for the infant. Again, I think just to prioritize, the priority is really around both for the maternal health, but also for the infant, is to get this mother suppressed and trying to leverage as many supporters in her life in order to get to that goal would be the important thing to go. So I think Bahati is going to be the most important person in this patient and to give us the answers. Bahati?
Thank you, Mo. So I think I do agree that some of the cases, like the one that you presented, are quite complex. And when we think of them, we often then think of what can we do for the client or for the patient. But I think it's also important to start thinking of ourselves as healthcare workers when we are managing complex cases, that how can I get support to effectively manage? So I think building a robust team, so it's not falling on the hands of one person, because that can feel quite overwhelming. So I know she went for a psychological assessment, that she may have gone for therapy and a psychiatric review. What I wasn't clear on is, was this ongoing? And does that need to be reinitiated or reactivated? She has a diagnosis. Can that diagnosis be reviewed? Is the medication still valid? Should it be reviewed as well by a team that specializes in that? I also think in terms of addiction, that was mentioned, we need to look at what would be the best option for her. Is she an outpatient person? It sounds more, though, I don't have too much information, but it sounds like she may benefit more from an in-house intensive treatment center rather than being an outpatient. And then that might help with things like her adherence once she's in a facility that could help her with that. I think having family sessions is key. The family sessions also gives expectations, knowing that things like conduct disorder or oppositional disorder, and if her diagnosis is reviewed maybe to a cluster B personality issue, to know that it's long-term and not short-term, and to know what to expect from their daughter, to know what kind of support she's going to need. I think sometimes families are unaware of what is going on and what realistic expectations they can expect. And so maybe when this young girl lashes out, it's just seen as, oh, again, she's at it again. But when you sort of understand that lashing out is going to happen, you're more prepared for it. So I think preparing the family for some of the dynamics that happen within their relationships. I think it's also key to then also, if this young man, I think he's 13, can also get his own therapy. The conflict with the sister, often we focus on one person in the family and then the other one is forgotten. Yes, they're their index patient, but I think it's important that holistically the family is seen, so that this young brother, this mom, can then become effective social support networks for her. I think it's important to continue her individual space. The conduct disorder and ODD lie around control. And so if she has a therapy space where she is in control. She's mostly in control. And maybe she feels less threatened. She can start talking about things about her pregnancy, understanding how her behavior impacts on her unborn child, also on her maternal health. It might feel less threatening than the doctor saying you must adhere, because then maybe she'll try and get control from that and then not adhere. So if she has her own space where she feels more in control and where she can process the internal conflicts that are then seen as the behavioral difficulties are important. But I think it's also important to note that not every case is going to come out perfectly. You may have a multidisciplinary team, but it's still not realistic that we're always going to get 100%, but it's about trying to do what we can. Thanks, Agnes. I hope that was helpful.
I hope that was helpful for you, Nicola, sorry. So yeah, I mean, I don't even know where to start. Just listening to all the conversations. Thank you, Bahati, for those insights. Just listening to all the conversations has made me think it's almost easier to manage treatment than it is to manage psychosocial. With treatment, we've got tests, we've got various lab tests, we can observe therapy, we can, we've got all sorts to tell us what needs to be done. With psychosocial, for me, it requires time, it requires patience, it requires what we call patient-centered care, which we don't often have the time to practice in real life. So my question to you, Bahati, I know you've provided us with some tools that we can also use to try and understand what's happening in a child's life, but without the most important resource, which is time, because health providers are often rushed to make sure that every child or adolescent has received their lab test and they walk out with medication in a health facility. What's your advice to healthcare providers in facilities where, those are their priorities and they, challenged in terms of time to do justice to understanding what's happening in our patients' lives?
Thanks, Agnes, for that question. I will sort of answer it in a roundabout way and say that I would still try and think that a mindset shift that mental health is a nice to have, or psychosocial support is a nice to have and secondary to everything else. So I want to lead with that yes, time is constrained, but I still think it shouldn't be something that is ignored, because the psychosocial issues are going to impact on your clinical management. You're not going to achieve the clinical management goals often if you don't then address the psychosocial issues. I think if you are limited with time, so asking 2 questions, for example, how has your mood been since the last time I saw you, or in the last 3 months before you came to the clinic? If that person indicates somehow that no, it hasn't been okay. If there is someone in your setting, a counselor, a peer supporter, I think we need to think broader than a psychiatrist or a psychologist. But is there a peer supporter who can help? Is there a model in your setting that facilitates a referral? I think a referral is key if you are time limited. I think it's also important, if you're time limited, to try and get knowledge on non-verbal cues. So your patient is disheveled, not well kempt, not in a demeaning sort of way, but you're noticing that in terms of their general appearance, they're not looking okay. Could it be psychosocial? Noticing those things. And you don't even have to ask the question, but you can say, I'm thinking maybe I can refer you to whoever it is that is able to then take time to do an assessment with that. But I do want to reiterate that psychosocial, focusing on the psychosocial is not a thing to think of, oh, we will do it 10 years later. It's important for us to start acting on it now. Thanks, Agnes.
Thank you so much, Bahati. And I think you give us a few tips there to, if, if we don't have time, there's at least one question we can ask. We can look at our clients and try and understand what's happening in their lives, use of peer support models. So I mean, I'm not even going to try and summarize all of them, but thank you for those pointers that we can implement. Now, before we close, this has been an amazing session. And thank you, a huge thank you to all our presenters and to our expert panel. And I just would like to encourage, if you're a health provider sitting on the platform thinking, oh, I had this case and I don't know what I could have done differently with the case. Please reach out to us. Would love to hear your cases and to give you a platform like today where you can share with your peers and you can hear from our expert panel in terms of how we can support you in supporting children and adolescents. So on that note, I'm going to hand over to Nandita to give us, I don't know, she has a challenge to summarize all our lessons from today into one slide. That was the brief, but I'm not sure whether that's possible because I think there's been so many lessons, both clinical and psychosocial. So Nandita, over to you for our closing takeaway lessons. Thank you.
Thank you, Agnes. And I know we're sort of over our time limit. I just want to go back to before I sort of close, I want to go back to two comments that were made actually in the chat. First, regarding this last case, and I think this last case, that's the kind of case that sort of stays with you because there are so many things to be concerned about. We're concerned about this young woman. We're concerned about her infant. And as Irene pointed out in the chat, we actually also have to be concerned about her partner as well, as she's not disclosed to him. Now, we can't force her to disclose to him, but we, again, this is an opportunity to talk to her about you equals you. That can also be something that is motivating for young people. It may be an opportunity to offer him prep so we can talk to her about the advantages of this and how he may be able to provide support. But I just wanted to raise that as, again, this is a very layered case with lots of issues. As Bahati was speaking about, what is it, the little bit that we can do even if we don't have time? And one thing that also is really important to think about, and again, this is sort of putting psychosocial issues sort of first and foremost above everything else, is to develop a trusting relationship with your client. So even if it doesn't happen on the first visit, but over time, your approach with this young woman, if you're supportive, if you're gentle, if you take a little bit of to listen to her, that really builds a therapeutic relationship that can benefit in the long term. And so just some of the key takeaways, and again, I think Bahati, you nailed it. It's really important, the integration of behavioral health, the thinking about psychosocial issues, even just that alone without any change in clinical management can improve clinical outcomes and improve patient satisfaction and bring them back into care. One thing I always want to point out is that some of these cases go for years, and yet, we're really still have the details, or the clinic still have the relationship with the patient that they are returning to them. And so I think that's a positive that we have to, again, remember that we are the ones that the, clients are coming to see as healthcare workers, and building that trusting relationship is critical. We also have talked about sort of the documentation issues, and again, historical information about past regimen use, especially reasons for change, as we're not just changing because of failure anymore. Family histories of what's going on with the family, the parents, the brothers, the sisters, close friends, other comorbidities, whether it's a behavioral or psychiatric issue, or whether there's another issue going on. These are the things that are really critical to document. And so I think when we are also approaching our patients and caring for them, a lot of things may be in our mind, but we want to make sure that we are capturing the most critical details so that that patient history is maintained, because more and more we make decisions based on the longer term history, not just at a snapshot in time. And lastly, just to point out that we are moving into a new era, just as some of our paradigms around what's first line and what second line is changing. We're also seeing now that you know, we have had HIV around for some 40 years, 30, 40 years. And we have many young people who have been perinatally acquired HIV infection that have now grown into adulthood. And we sometimes try to make this difference between, oh, if they're older, they're more likely to have horizontally or sexually acquired, behaviorally acquired HIV versus those that are perinatally infected. And those things, I don't think we can count on that anymore. So we do have to recognize that there are some now young adults or even, you know, getting into adulthood that really have spent their whole life dealing with this and all the challenges that come with it, whether it's from inappropriate regimens, whether it's from frequent illnesses or missing school. So we really have to be a little bit more attuned to what where our patients are coming from. So I want to thank the presenters for providing such rich cases. And I think there's a lot to learn from here, and we look forward to hearing more of these. Thank you very much, everyone.